healthcare innovations and ensure that they are available to patients of all backgrounds. Before we turn to our panel, we do have an exciting discussion with Dr. Natasha Corbitt, Assistant Professor in the Department of Surgery at UT Southwestern Medical Center and Director of Bench and Translational Research for the Division of Pediatric Surgery at Children's Health in Texas. Here's her recent conversation with US News Managing Editor Liz Whitehead.
Welcome, Dr. Corbitt. Thanks very much for joining us.
Thank you so much for having me. It's a pleasure to be here today.
One very serious condition impacting infants is biliary atresia. As a surgeon and physician scientist who's been working extensively on the diagnosis and treatment of this condition, can you describe what it is, when it is typically diagnosed, and how serious it is?
Absolutely. Unfortunately, we don't really know what the cause of biliary atresia is yet. But we know that the disease manifests as obstruction of the bile ducts in babies, and that's usually reflected by persistent jaundice. This progressive scarring of the bile ducts leads to obstruction in babies with biliary atresia, and this causes cholestasis or buildup of bile, and then that causes liver damage. And so it's really important to make this diagnosis of biliary atresia as early as possible so we as surgeons can intervene as early as possible, and that gives the babies their best chance of preserving their native liver.
So since early diagnosis is so important, can you talk about who sees the early signs first? Is it the pediatrician, and is it generally, within a week or 2 or 3 weeks after a baby has gone home? What do they see first, and what's the first test?
That time range is pretty much right on par. Sometimes parents see or pediatricians will see the external signs of biliary atresia, which is typically yellowing of the skin or eyes, so jaundice, or even they can notice pale stool color. The stool can look like clay or chalk. A lot of babies are born with some jaundice, and it usually goes away on its own, but if it persists beyond 2 weeks of age, then that's when pediatricians and parents really need to start thinking about further evaluating that jaundice. One of the main test to be able to assess the jaundice is by checking bilirubin levels, and so that's particularly helpful because if the direct bilirubin is high, that makes biliary atresia a possibility.
When you say high, can you say how high?
Yes.
Go ahead.
Checking the bilirubin levels, direct and indirect levels, can really be particularly helpful in making biliary atresia a possibility, because in biliary atresia, the direct bilirubin is usually elevated, and that's usually more than 20% of the total bilirubin, or greater than 1 milligram per deciliter.
So, as you mentioned, speed is of the essence in diagnosing this condition. So you've got the high bilirubin results. What are the traditional tests that are next in the progression to try to figure out if this baby has biliary atresia?
That's a great question. I wish that there was one right answer. There are a lot of tests actually that providers use to try to get to the diagnosis of biliary atresia. There's no exact right way that all centers do across the nation. Everybody does kind of a little bit of something different, but some of the options are, once you know that the baby has jaundice and they have an elevated direct bilirubin and biliary atresia is on your radar, you can get an ultrasound. And so an ultrasound will help you look at the baby's liver and duct anatomy. And sometimes that can reveal like a congenital anomaly or like a biliary cyst, and then you can do the treatment for that, right? But if the ultrasound is normal, that doesn't necessarily rule out biliary atresia. Another example of a test that people use to try to work up biliary atresia is a nuclear medicine scan or a HIDA scan. This is a test that actually helps determine if the biliary tree is open or not, which is really important because the biliary tree is blocked in biliary atresia. But it takes 5 or so days to prepare for this test because babies have to get pre-medicated and get optimized for the test. And then there's some more invasive tests. And so At some centers, they have a specialist and a gastroenterologist who's an advanced endoscopist. They can do a special procedure called an ERCP, where they put a scope into the intestines, they shoot a little dye into the bile ducts, and then they can see if the bile ducts are open or not with x-ray. You can imagine this is really hard to do in a small baby, right? And it takes a really skilled proceduralist, and it takes specialized equipment that all centers don't have. And in fact, it's probably pretty rare for centers to have a advanced endoscopist that's able to do this in a small child. And then at some centers, they do have pathologists that are really specialized in looking at liver pathology. And so if a baby gets a liver biopsy, they can assess it and see if there are signs that are suggestive of biliary atresia. But they don't actually rule in biliary atresia. The gold standard to make the diagnosis of biliary atresia is an intraoperative cholangiogram. And, you know, that's surgery. And so you can imagine there's a little reluctance with committing to a diagnostic surgery in a small baby. I do want to emphasize how important it is to reach the diagnosis quickly. And you can imagine that all these tests take variable amounts of time. But for biliary atresia, every day a baby gets older, you can picture their liver injury is getting worse, right? And so the likelihood that they'll end up needing a liver transplant goes up. And right now, 2 out of 3 kids with biliary atresia will end up needing a liver transplant.
And obviously, it's the prognosis for kids getting a transplant is, you know, much less positive than those who are able to keep their own livers.
Absolutely, because, you know, liver transplantation requires lifetime medication, lots of complications related to liver transplant, even in today's age, even though a lot of advances have been made in the field.
So with that in mind, you and your colleagues have been looking for improved diagnostic approaches that are perhaps less invasive, allow the possibility of getting answers more quickly to stave off this scarring of the liver. Can you talk about this new approach that you've been working on and a sort of a very promising pilot study that you've completed?
Yeah, I would love to share a little bit about the work that we've been doing. And so, you know, one of our goals is to be able to assess if the bile ducts are blocked or not in a non-invasive way. As a surgeon, I love surgery, but, you know, it would be really great for these kids if we could come up with a really good way to make the diagnosis without doing surgery. In surgery, though, one of the ways that we can see the bile ducts a little bit more clearly is by using this fluorescent dye. It's called indocyanine green. And what's so special about this dye is that when you give it through an IV, it gets goes into the blood and then goes into the liver, and then it all flows through the bile ducts. So we can see the bile ducts really clearly in surgery. But after it flows through the bile ducts, it empties into the intestine, just like bile does. And so if there's no blockage in the bile ducts, then the dye will end up in a poopy diaper, just kind of like bile does. It ends up making your stool pigmented or colored, you know, yellow or green in babies. And so in our initial testing, we found out that this fluorescent dye, indocyanine green, after we give it, it reaches the intestines really quickly, sometimes within an hour, as long as everything is open. And even in kids who have elevated bilirubin, the dye can still reach their poopy diaper within 24 hours if the bile ducts are open and they don't have biliary atresia. But when we give it to patients who have biliary atresia, whose ducts are blocked or obstructed, then the fluorescent dye, it can't make its way out. It won't reach the intestine or the soiled diaper. And so in this way, if the dye makes its way all the way through, then we know that the bile duct's open. And if the dye can't make its way all the way through, then we know that the bile duct is blocked. And we can assess these diapers to see if the dye's made its way through just by using a special camera and figure out the results within 24 hours.
Just a quick follow-up on that. Since the damage is progressive, do you have situations where you could have a partial bile duct blockage and some of the dye might get through, but then it will close up?
Yeah, so biliary atresia is progressive, and so you know, the scarring of the duct might not cause a complete blockage right when the baby is born. That might happen over a couple of days or even a couple of weeks, but it happens very quickly. And so let's say that we gave the fluorescent dye and it went through, but we were still concerned that the baby had biliary atresia and that things were progressing. We could definitely give the dye again, It's totally safe to do that and very easy to do that. And certainly with the concept in mind that biliary atresia is an evolving and progressive scarring disease. And so, you know, there's no age or size minimum, and the dye is pretty inexpensive. So it's not very burdensome to have to do it again.
What is in your initial study, what was the accuracy and sensitivity of the test?
Yeah, so conceptually, the test is just like doing a cholangiogram in the operating room, but without the surgery or the X-ray. And so the sensitivity in our initial study, in a little over 20 patients, the sensitivity was 100%, and the specificity was 85%. And we just have compiled all our results together and submitted to the Journal of Pediatric Surgery, and so that's going to be published soon. And so we're hoping to, repeat the study in a really large cohort of patients across the Western United States.
Wow.
In the Western Pediatric Surgery Consortium, so that includes 10 other children's hospitals, just so that we can get increased diagnostic accuracy by enrolling more kids.
So is that something that you hope to see begin in 2024?
Yes, ma'am.
Oh, that's really exciting. In general, when you're dealing with these fragile infants with these serious diseases like biliary atresia, how important is just continuing to refine diagnostic testing?
It's super important. I think, in fact, it's the most important thing. These kids' lives depend on it. I think that, the way that, and what we know about biliary atresia without actually knowing what causes it, the best way to improve the outcomes for these kids is by making the diagnosis as early as possible. And so by developing new diagnostic strategies and new testing strategies, we can minimize, some of the burden on these kids of going through multiple different procedures or multiple different tests or even surgery if they don't need it, but also expediting, the diagnosis, and so that they can, get treated as quickly as possible. I think what makes this test so promising is how quickly we can know the result, and so far how sensitive it seems to be. And so if we have a really sensitive test that can be done really quickly, that might help some kids be able to get diagnosed faster, get intervened on faster, give them their best chance to keep their own liver and not need a liver transplant.
That's really encouraging. Thank you, Dr. Corbitt, for sharing these very promising findings. As you noted, the continuing refinement of diagnostic approaches for diseases like biliary atresia offers the hope of substantially boosting the long-term prognosis of many young patients, and that's exciting. Thanks very much for sharing your time and your expertise.
My pleasure.